So first of all, I'd like to thank our sponsors who are in the back of the room. Without them, we would not have been able to financially put on this symposium. They were a great help. And not only that, they are terrific treatment providers. So if any of you have questions about what is inpatient treatment, personal situations, what happens in treatment, these folks in the back of the room can answer those questions. We also have sober living providers back there, and if you have any questions about that, they'll be able to help you with that as well. I'd also like to thank Kelsey from the Hotel Jerome. She's made this really seamless and easy for me. When I kept saying, we're gonna need more chairs, we're gonna need more chairs, we're gonna need more food, she's like, no problem. And Chris from PSAV, right over here, is also helping me with the technical aspects of which I know nothing. But very importantly, and I think they're still at the registration table, I'd love to thank our staff and volunteers. They're really the crux of our program, and they handle crisis calls every day. And without them, a way out wouldn't be what it is. So I'm extremely grateful for the staff, and even though I think most of them aren't in the room, could you give them a round of applause? And last but not least is the Away Out Board of Directors. Would you guys come up on stage really briefly? They don't want to do this. So the Away Out Board of Directors hired me back in 2012 because they really wanted a nonprofit in the Valley that would help people who did not have resources and did not know where to go or what to do to get help with addiction. And it was really their brainchild that is the reason we're even here. An organization called The Right Door closed in 2012, which left the Valley lacking any resources. And so these folks came up with, and they said, we've got to help people. We've got to get them help. And we started, I think, in 2013, helping about 50 people. And as of count last week for 2018, we've already helped 207. So we're growing quickly. It's the board's fierce dedication to reducing the revolving door of addiction and helping the children and families affected by addiction. It's really admirable. So thank you. Last but not least also is our esteemed presenters here today, who will be introduced by board members and people that friends of A Way Out. Their national and international recognition is some of the best in the field and is well noted. All of them have written about compelling topics related to addiction, recovery from addiction, the family, young adults, and the effects of trauma and addiction on the family, and much more. We did not have a book table here today, but Explore Booksellers, 2 blocks away, has their books on hand for you, should you want to buy them. And I just want to say I'm so grateful for the presenters' willingness to travel from far and wide to be here today. Because of the increased problems of addiction in our beloved rural mountain towns, A Way Out was formed, as I said. Scholarships are provided to ensure people without resources have access to critical care to overcome an addiction. All monies we raise through grants, fundraising events, and individuals support our programming. About 85% of all monies go to direct care. When we started, we first helped people get to inpatient care. And we thought, wow, this is really great. And then we realized inpatient care is only 30 to 90 days, and people were not getting over the brain disease that addiction is. And then we thought, boy, they're not getting well, not completely well. So it was at that time that we realized that we needed to create a continuum of care so that people could hold on to the beginnings of new recovery. And we then, working with treatment providers here in the Valley, as well as creating our own programming, created a year-long aftercare program to support people for a year. Because if you've had an addiction for 10 years, 20 years, even 3 years, the thought that you're going to get over it in 30 days is wishful thinking. Some people can, but most can't. So we have started, let me find my place here. We have our Year of Care plan includes a family engagement program to support family members. We have ongoing clinical support. We have an alumni program. We have a transitional housing program. And we support IOP programs here in the Valley for our clients. So we attack it from a number of different angles. We also have bilingual individual and family counseling. We also support children and teens. So we look at helping solve the substance abuse disorder problem as a continuum of care for the individual and the family. Our mission is to provide individuals and families in crisis with drugs and alcohol access to treatment and recovery support. When I thought about talking, I'm guessing almost everybody in this room has dealt with addiction in one way or another. If anybody, I don't know if you want to do this, but would you raise your hand if you've know a loved one personally or a friend who has struggled with addiction? Would you raise your hand? That's what I thought. Yeah. I personally grew up with addiction in my family. I have 6 family members who struggled, and they're all gone now. People very close to me. We had this kind of policy growing up, and I remember looking at all the other families when I was in school thinking, wow, their family looks so much better than my family. And that's how I measured it. And in my family, it was like, don't talk, don't tell. Just don't talk about it. Just we want everyone to think we're okay. And and looking back at that today, I think that kind of policy is in a large part why they're all gone. They did not seek help. I didn't know what to do. I went on to drink my way through college, party like crazy, until I realized that, ooh, this isn't working for me. And I'm really blessed, because most of my family members are still struggling with alcohol today and drugs. So I think if anything else that we can take from today's presentations is that we need to talk, we need to tell, we need to bust this out of this little cocoon that it's no fun to talk about addiction, but we've got to, because people are dying out there. Interestingly, the ripple effect of addiction on families, friends, and communities, while well documented, is still not talked about all that much. And it's growing. The amount of people that are hurting, that are dying, is growing. Our local jails, law enforcement, businesses, schools, hospitals, and social services, to name a few, are consumed with dealing with the addiction problem. Substance use disorder, particularly the opioid crisis, is being described as the biggest man-made epidemic in the US. Approximately 1 American is dying every 17 minutes from an accidental prescription overdose alone. And that's just accidental prescription overdose. That's not heroin. That's not alcohol. So how many every minute are dying? While most of us, again, don't like to talk about addiction because there's a lot of fear of judgment, and shame attached to it, we really must. This symposium is about all of us coming together. And I want to thank you all for caring enough to be here. Now down to a little housekeeping. There were index cards on your seat, and those are to ask questions. We're going to have 2 bathroom breaks, one after Dr. Mel Pohl and one after Dr. Claudia Black. And when you have questions, write them on those cards, and then there's baskets at the table on the back here, to my left, your right. And then William Moyers will present, and write your questions down for him, and we will collect those after his talk before they get up here to do the panel Q&A. We will also have roving mics if you have a burning desire that didn't get down on those questions. I'd like to introduce someone who grew up here, who's near and dear to my heart. Her name is Betsy Farver, and while you may or may not know that name, I bet you know her brother. Her brother is Steve Wicks, who is a well-known local here and has been a supporter of A Way Out, but also he's a supporter of so much in our valley. And so we're grateful to have Betsy here. She's hot shit, quite frankly. Betsy received a Bachelor of Arts in Psychology from the University of Southern California. She has a Master's of Arts in Addiction Counseling from the Hazelden Graduate School of Addiction Studies. She has a degree in, and I should probably get one of these, exponential fundraising from the Harvard University Kennedy School of Graduate Studies. Betsy was also, back in the day, on the Aspen Valley Hospital Board. She's been on the Betty Ford Center Alumni Board. She is a member of the Central College Board of Trustees in Pella. I'm just getting tired reading all this. And she has been president of PEO for 2 two-year terms. She's done a lot. Betsy has really dedicated her life to helping people recover from addiction. She has been executive director of clinical services at the Betty Ford Center and vice president of philanthropy and alumni relations at the Hazelden Betty Ford Foundation. Would you please welcome Betsy Farver?
Good morning. It is such an honor to be standing before you all here this morning, and I got to tell you, the thing that makes me the most nervous is that my brother is sitting in the audience. But what I will tell you, what Liz said, that he's so supportive of different organizations and things happening around the Aspen area. He is most supportive of his sister in recovery. And his 94-year-old mother, who's also in recovery. So that's a real double whammy, Stephen. So I guess as I'm sitting here learning more and more about A Way Out, as Liz said, and thank you for that nice introduction, Liz, and I'd also like to thank my dear friend Caroline Koshner for volunteering me for this opportunity. It feels like an oxymoron, doesn't it? But any excuse to come to Aspen, and since I'm from Palm Springs, I'm taking total credit for this weather. I want you all to know, so thank you, Caroline. And I've done a lot of fundraising, as you heard from Liz, over the years, mostly in the treatment field. And a way out is not only a fundraiser's dream, but it's also a donor's dream. Because, and there are several reasons. Number one, you heard Liz mention, and I'm going to reverse her statistic, their administrative costs are 15% of all the money that they bring in. That is unheard of in this field and something to be commended. And a lot of that is because of you, Liz, and because of your tireless volunteer board. You know, that's what makes all that happen. The other thing that, one of the other things that Liz didn't mention is that they are, they're the whole package. When you're in late stage, when anyone is in late stage addiction, the family, the addict or alcoholic, it's a really dark time, and you have no idea where to turn. You don't know any. When I went to treatment 22 years ago, it was pretty simple. You called the center, they had a bed, they didn't, you go in, whatever. Today, it's a very, very complicated process, and there are many, many treatment centers, as you all know. I'm preaching to the choir, all over this country, all over the world. And what A Way Out does is, first of all, they take motivated people. That is huge. You have to write a letter to apply for a scholarship. And that's half the battle if someone is ready to get well, again, as you all know. And they match the client with the appropriate treatment center. It's a win-win. And then they catch them as they come home, so to speak, with their year-long aftercare and keep them involved a long time during alumni processes and events and whatnot, which are just starting, I know. Plus, they work with the whole family. It's a family disease, we all know that. And, the fact that they embrace the entire family, I mean, this is a huge service, and it's really very rare in this day and age. Aspen is very lucky to have A Way Out, I think, here in the Valley. So it's also a very worthwhile endeavor. I'm repeating myself now. I've been a fundraiser and a donor, and I look at it from both aspects. And as I said at the beginning, it's a win-win. So for those of you who have contributed to A Way Out, thank you, thank you, thank you. Your dollars are well spent. You heard the numbers from Liz. We're already ahead of where we were for the whole year last year. So that means more dollars are needed. And the more dollars that come in, the more people we can help. That's the bottom line. So thank you all for your help. And it is now my pleasure to introduce Dr. Mel Pohl. He is our first presenter. I've never heard him present, and I told him this morning his reputation precedes him. I'm really excited to hear your presentation, Dr. Pohl. He is certified by the American Board of Addiction Medicine and a distinguished fellow of the American Society of Addiction Medicine. He is also the chief medical officer at Las Vegas Recovery Center. He is quite a prolific author, authoring many books, including A Day Without Pain and The Pain Antidote, Stop Suffering from Chronic Pain, Avoid Addiction to Painkillers, and Reclaim Your Life. And just recently, in 2016, he was featured in a program about chronic pain on public television. So please welcome Dr. Mel Pohl.
So how many relate to this title that we missed the boat? Does it seem that way to you? It seems that way to me, and I'll spend the morning sort of giving you some perspective on the opioid epidemic, the opidemic, if you will, that faces the United States and really the rest of the world. We are 5% of the world's population in the United States. We consume 80% of the world's opioids. So things are happening here. 49,000 deaths in 2017. That's 150 deaths per day from opioid overdose. So how did we get here? Well, the first point of perspective is that what we did was we conflated acute pain and chronic pain. That's really the fundamental error that we made as a medical profession and as a culture, if you will. Everybody's familiar with acute pain. If you've ever sprained your ankle or broken a limb or had an infected tooth, it's pain related to tissue damage. When the tissue damage heals, the pain goes away. We can measure the caliber of the tissue damage with x-rays and MRIs, and we can decide what to do. We can treat that tissue damage, and the pain will go away. Does that make sense to everybody? Well, the fallacy, the mistake that we made was we went down a road thinking that chronic pain was just more of the same. So you have acute pain, and it goes on for more than 3 months, and then you have a condition that's known as chronic pain. And that's just not the truth. Chronic pain is a different process, but let's look at the fallacy for a moment. If we think that chronic pain is like acute pain, then it's related to what? Tissue damage. If it's related to tissue damage, we ought to be able to measure and calibrate that tissue damage. I have a bulging disc at L4-5. The amount of my pain should be directly related to the size of the bulge and the pressure on the nerve. How will we tell that? Do an x-ray as I've had, and do a CAT scan, and then do an MRI, and then stand you on your head and then do an MRI in that position, and then inject dye and see if it slides through the bulging disc area, and then inject the disc area. Anybody had a discogram? That's what we do. We inject dye into the disc, and if it hurts, that's diagnostic of the condition. So now we've diagnosed this poor sap with a big old bulging disc after we've caused him this incredible amount of pain. What are we going to do about it? As a culture, as a medical profession, what we end up doing is we throw a blanket on it. We give you a bunch of drugs that suppress the brain's pain signal. Or, what are we going to do? We're going to go after the tissue damage. We're going to operate. He's shaking his head no. Dave has not. Do I want to ask why you have a thing on your... You had 4 surgeries. And now you have a label on your head to find out who you are. I won't ask. Sorry.
A lot of explanation.
Yeah, after at the break. So we're going after it. We're operating on it, taking out the source of the tissue damage, and what should happen? Should get better. What percentage of people get better who have back pain and have back surgery? Less than 20. So, and then comes the worst lie, the worst fallacy of all. And that fallacy is that if I can't find tissue damage causing your pain, or if I've repaired the source of your pain, which is the tissue damage, you should be better. And if you're not better, what? Must be in your head, or it must not be real, right? So let's take a moment and realize that I am here to tell you the truth. And I tell you the truth because I learned a lesson a long time ago. I lived in Minneapolis, like our third presenter, for 3 winters. And I had 2 Russian wolfhounds. The female was an angel. The male, on the other hand, was he was a dog. And he had 2 character defects. Some of you people know what I mean. One of his character defects was he dug in the yard, and the other one was he had an affinity for small furry creatures. It happens. So one day he came home. We lived in this lovely suburban neighborhood in St. Louis Park and open properties, and he came home and he had in his mouth something, clearly something furry and dirty and bloody, and I wrestled it from his mouth, and it turned out it was a little rabbit. And it was the pet rabbit of the little girl next door, named Fluffy. Dead, muerto. Well, I was just mortified. And I was new in recovery at the time, and I said, well, we're just going to have to go next door, face the music, offer to repair it, apologize, do whatever we can. And my partner, Denny, was not in the program. He said, well, no, that's not what we're going to do. We're going to tiptoe over tonight, and we're going to put that dead rabbit back in the cage, and they'll think it died of natural causes. I said, look at it. It's bloody. He said, not to worry. So he took that dead rabbit and he put it in the laundry sink and he got the shampoo out and he washed off all the dirt and the blood and put the conditioner on and got the hair nice and soft. And then he blew all fluffy and nice, and he looked like he was sleeping. Well, I didn't sleep that night. Then he went over and deposited him in the cage, and the next morning, Sue would come over and visit every morning, have coffee, and she looked terrible, pale, and I was sort of ready. And I said, what happened, Sue? And she said, oh my God, the strangest thing happened. Fluffy died a week ago, and we buried him in the yard. So the truth is, I am truly here to committed to the truth. The truth is, let's start with the biggest truth about chronic pain, and that is that all pain is real. And we've missed this boat. Oftentimes, people go into a doctor, or they're hanging out with their family, or they're at work, and they say they're in pain, and the response is disbelief. And that disbelief costs us. It costs us in our ability as a patient to relate to the person who we rely on to give us care. You know the studies that say it is not the kind of antibiotic that a physician prescribes or the method of therapy that a therapist uses. It's the connection, the relationship between the patient, the client, and their therapist and their doctor. And the disbelief disconnects that patient from their doctor on day one. I work in Las Vegas at a center for people who've had chronic pain for years, mostly who are dependent on potent anti-pain drugs, painkillers, and they come in feeling disbelieved. And the very first thing that I can do for them, and the very first thing if you're in the field of addiction treatment, you can do for them is just sit and validate and acknowledge the fact that their pain is real. Very important. Now, some people have a need to make a point. They need to convey how bad the pain is. You might say they exaggerate their level of pain. So, a common answer to what's your pain score in my office is it's a 15 out of 10. Well, it's legitimate to say, no, it can't be 15 out of 10 because 10's the worst ever. 10 is called the ambulance, or the wambulance, as my niece Jackie would say about my complaining nature. But the pain is real. And when we look at our watch or roll our eyes or internally, you know what I'm talking about? When we don't believe that that person is in as much pain as they say they are, we disconnect from that person. And we get in the way of our ability to impact that patient's care. So that's the first truth about chronic pain. Now, the confusion comes from the fact that people don't understand the genesis of the pain. So I get asked very often by very sophisticated interventionists and physicians and referrals or families, doc, I'm not sure if it's real pain or if it's emotional pain. Which one do you think it is? And I always say the same answer. Yes. Yes, it's real pain, and of course it's emotional pain. And the second truth is that emotions and the thoughts associated with those emotions generate 80% of the explanation of the experience of chronic pain is related to how we think and feel about it. Now you can imagine how happily that greets my patients who are admitted to the hospital. I get a lot of disgruntled looks and worse. But the truth of the matter is, it's how the brain processes the signal that is responsible for the experience of chronic pain. And the corollary to that is that until and unless a person is willing to deal with their thoughts about the pain, how many have said, my back, my knee, my shoulder is killing me? Come on. Yeah, and look at you. You're all here, alive. So some of you who are therapists in the audience understand cognitive distortions. My feet are on fire. Let's get the fire extinguisher, I can't get out of bed. What if the bed were on fire? So we lie to ourselves, the narrative is not true, and we have emotions, fear, anxiety, anger, depression associated with those faulty thoughts, and with the distressing experience of pain, and we end up increasing the level of pain. Fear of the pain is worse than the pain itself. And we have studies, we have scans of the brain, and it shows that acute pain is related to a particular part of the brain. Chronic pain is housed in a different part of the brain, the limbic system. People familiar with the limbic system? It's where we feel emotion. And it turns out that's where addiction happens. So the parallels between chronic pain and the disease of addiction, the drive to get relief pathologically, are very, very significant. Well, this third statement is going to shock this audience, I'm sure. And that is that opioids often make the pain worse. Opioids drive pain levels up. They are pro-inflammatory. So they cause parts of the brain to light up that are not lit up. So people on chronic opioid pain on the drug than off the drug, which means the treatment, the proper treatment of opioid dependence is to take people off the opioid. Guess how excited people are to hear that message when they get to treatment. I'm going to take you off your opioids and you're going to have less pain. But if people know about addiction, you know that if you take opioids on a regular basis, you are physically dependent on the drug. And when the level of the drug goes down between doses, the pain level is going to go up. So, and furthermore, there are actually inflammatory processes in the brain that cause the pain level to go up. If you're interested in this, it's opiate-induced hyperalgesia. More pain on the drug than off the drug. Now, the fourth principle is that if we're going to treat, we want to make people better. It's time to really pay attention to function. If you've ever gone to a pain doctor, or even to a physician with a complaint of pain, what's the first question that the doc asks? We should be asking, how's your life? Are you engaged? Are you walking? How far do you walk? Do you work? Do you have joy? Are you hanging out with your grandkids? Or are you in bed most of the day? We ought to be making people better with our intervention. You know, looking around the room, if you're in pain, there isn't anybody whose pain I can't take away. Maybe 300 milligrams, maybe 350 milligrams of Demerol for some of you. You know who you are. But you would be out cold. That's not good treatment. We want you up and around. Do you know the professional standing of people who do pain treatment, chronic pain doctors? Do you know what their specialty is? Anesthesiology. Do you know what anesthesiologists learn how to do in training? You know, that's a pain-free state, general anesthesia. That and death are the only two pain-free states. So we really are going to, what we really want to do is not ask you about your pain at all. We want to ask you about your function, and we want to drive the function up in a better way. And then finally, expectations influence outcome. We have data sets that say if you believe something's going to happen, it's more likely to happen than if you think it's not going to happen. Cognitive behavioral therapy works 40% better in people who believe it's going to happen. Our job as therapists and physicians is to motivate, to instill confidence. Turns out pessimists have a more realistic view of life, but optimists live longer. Placebos work. How do placebo is a sugar pill, an inert substance that if I give everybody in the room this pill and say you're going to have less pain in 20 minutes, 25% of you will have less pain. That's just about as good as most opioids in terms of their efficacy. There's also a nocebo effect, negative. So I give everybody in the room a pill and I say in 20 minutes you're going to have excruciating abdominal pain. What percentage of you do you think will have abdominal pain? 90%. The power of the negative is incredible. So what do you think happens to the patient who continually tells themselves, I can't take this, I can't stand this, my life sucks, this is the worst thing that ever happened to me, I want to die. That negativity resounds inside their limbic system and their pain levels go up. So a lot of the clinical techniques are about engendering somebody and bringing them through to the next level of belief and improvement. There are a lot of things that influence pain. One of them is how you were raised, the messages that you got in your youth. Did I mention I had back pain? I said a bulging disc. L4-5, pain radiates down my back, radiates into my buttocks. I have neuropathy in my feet, and it's quite aggravating. Raised in a Jewish household, And I love talking about it. We have Jews in Aspen, right, in Colorado? Yeah, I know who you are. My mom was a proverbial Cavette. She had disc disease of her back, and, how you doing today, Ma? That's all I had to hear. And the guilt would rise in my heart, Now, I really like talking about it, but I'm not going to do it for most of the rest of the morning, because in the context of this, I'm responsible for talking about chronic pain and educating you and giving you perspective. But if I was done, I got back to my limelight, I'm getting out the ice pack, and if somebody has the misfortune to call me, I will tell them every detail of where my back hurts and how it radiates. You got it. There are people, I've met them, who aren't like that, who are raised in a different culture, farms. Anybody raised on a farm? Pain. Their 3 is my 8. It's a different experience, but we have to be cognizant of that. Anticipation in previous experience is huge. I think it's going to happen is more likely to happen if I think it's going to happen. Well, if I think my pain is going to get worse, I'm going to feel better. We had a patient with chronic headaches. Her medication list was OxyContin 3 times a day, Vicodin 10 milligrams 6 times a day, Valium 10 milligrams 6 times a day, some Xanax if she had a panic attack, Ambien 30 milligrams at night, and Adderall 30 milligrams 4 times a day for ADHD, right? Or fatigue, whatever you want to call it. Her OxyContin dose 3 times a day was 9 o'clock, 10 o'clock, and 11 o'clock. So she was very dependent on these drugs. We detoxed her in a very complicated course, 10 days of pretty miserable time. But she was better. And she was at the nurse's station. She was free of all these opioids and benzodiazepines, ready to go, with a terrible headache. At the nurse's station, hollering, I have a 10 out of 10, worst headache I've ever had. I have to go lie down. Well, 10 o'clock in the morning is group time, the process group, most important group of the day. And you don't get to lie down during process group, even if it's your first day. So the counselor tried to get her to go. The nurse tried to get her to go. She got more and more entrenched in her pain. And then they called me. Will you talk to her, doc? So I went and I talked to her and I said, I'd like you to give a try to going to group. I can't go to group. Don't you understand? I have a 10 out of 10 headache. I said, well, go to group and try. She said, if I go to group, my head's going to explode. I said, oh, well, then you better sit near the door, and bring a pail. But if you go lie down now, when you get up, you should pack. Her mom, 72-year-old mom, had cashed in her 401k to send Carolyn to treatment. Carolyn spent 22 hours of the day in bed, 50 years old, for the last 20 years, with headaches. So I said, go to group or go home. Well, you can imagine she was not very receptive to that idea. Going down the hall, she's muttering and sputtering, that MFing doctor, he's crazy. And group that day was on anger and resentment. And guess who shared first? Carolyn talked about the unreasonable doctor and how they were forcing her and how she wasn't abusing her drugs, everything she took was prescribed, blah, 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 blah. And at the end of the group, she got a lot of good feedback and a lot of connection with people who had similar experiences, some with me. And at the end of the group, her pain was a 7. First time in 22 years, she had a different experience. And she broke that pattern. That was the beginning of her recovery from her chronic pain. So it was her emotional and cognitive that drove that pain level up. Cognitive distortions are key. We challenge the story. And I had a patient with terrible ringing in his ears, 72-year-old attorney, very successful. Life was decimated because of this pain. And his prevailing factor in his clinical presentation was fear. So I went into his room, and it was the 6th day of detox, and he was doing okay. And I said, what's going on? What's happening with your detox? And he said, doc, the pain's only at a 5. It's way less than I thought. He said, but it's rising. What does that mean? It's right. You're right here, right now. It's a 5. No, but it's going to be a 7 in 20 minutes. I just know it. Do you get it? The power of the cognitive process. So So our interventions really ought to be about interrupt those cognitions. How acute pain becomes chronic is very complicated. I'm not going to go into too much detail, but acute pain is transient activation, which ends. Chronic pain is sustained currents. Take my back. This nerve fires all the time, I can tell you, all the time, night and day. Sometimes I pay attention, sometimes I don't. But as a result of chronic firing, my brain has changed. Because our brains are plastic. They respond to stimuli and factors inside the environment. And eventually the pain is self-generated inside the circuitry of my frontal lobe, prefrontal cortex, and my limbic system. And this is where the pain lives, and this is where the pain treatment needs to lie. What it looks like biochemically, neurochemically, is a normal brain turns into an atrophied brain with a part that lights up being in the limbic system. So we need to be mindful of that. The last physiological thing I want to say about pain is that some people feel more pain than others. We've already established that. I'm a big kvetch, you know, I feel more pain than others. But we know that some people express and feel more pain than others. Does that make sense? Yes? That is related to a difference in enzyme system. COMT is an enzyme that metabolizes one of the neurotransmitters in the brain called dopamine. Everybody familiar with the dopamine is a neurotransmitter of well-being. Well, that certain people metabolize dopamine differently and that their experience of pain gets bigger in response to the stimuli. And there are other people who have a variant of COMT where the brain signal gets smaller and they feel less pain. Let me tell you what I'm talking about. Your name, sir? Rob? Robert? So Robert here, in this example only, this is not a personal attack, but he has the variant of COMT that makes the pain big. What that means is I go up to Robert and I poke him this hard enough to make my fingernail turn a little white, pretty light. And Robert, because of this COMT variant, says, "Oh my God, what are you doing to me? You're killing me. Please leave me alone. Don't no more." Now, what would we say about Robert? Don't be nice. It's a big wuss, huh? A little dramatic. Big wuss. We could get nastier, couldn't we? He's histrionic. He's exaggerating, overreacting. We would judge him because that's what we do. We judge people who are experiencing high levels of pain. And I just got through telling you, he has an enzyme that causes this. Your name? Stacy has the opposite. Her level goes down. I poke Stacy like that and she goes, "Dude, don't poke me. You know, I'll kick your butt." So we have a tough woman and a wuss. Right in front of us. There are two things that impact the COMT level. The first one is genetics. About 50% of the explanation of the pain threshold. So mothers have kids that have a heightened pain sensitivity. And daughters have mothers and fathers who had a heightened pain sensitivity while they were growing up. And the second thing, which we're going to hear about later this morning, is people who've experienced trauma. Where is it? So trauma causes an increased pain sensitivity. Now we're talking about childhood trauma, emotional, physical, sexual, life trauma, people who've experienced or witnessed. And what we see a lot of is medical trauma. People who've gone to the doctor, had a surgery, failed surgery, gone back for a second surgery, now they're on their third surgery for the level above and the level below the fusion, which means they got a titanium rod in their lumbar spine. That's traumatic because some of those people have complications and they end up in the emergency room on antibiotics for 4 months because of an infection in the surgical site. It's the kind of folks that we see. So trauma turns a normal brain response of pain. Look at the magnitude of the yellow bursts of energy into that. And that's called central sensitization. So in the example that I gave, Robert's brain, when I touch him with light touch, is an explosion of synchronous nerve firing that does not serve anything. It's adaptive pain. He doesn't need that pain. I don't need my back pain to survive. In fact, it's really just an annoyance, except I got something to talk about, you know. But other than that, it is not functional pain like a broken leg. So we've misinterpreted this pain signal, and our brains, Picture the volume knob inside the brain center of pain turned up. That's what people come to us with. And picture those people being exposed to a drug that gives them relief. And that's the beginning of the opioid problem. It's not everybody who has chronic pain that ends up in trouble. It's people who have the pain, but who also have that emotional overlay. So not everybody is consumed by depression, anxiety, anger, and fear. Those folks have restricted daily activity, so their function. They're using medications excessively and medical services, and they have non-productive tests. They want to be cured from this chronic problem that is uncurable, because the problem is in their mind, not made up, but it's in the processing of the signal. And they don't have the relationship to the organic disorder, so they have this misunderstanding. Pain is a subjective experience. On a scale of 1 to 10, what's your pain? It's whatever you say it is unless I prove it otherwise. Well, how am I going to prove that you don't have a 10? It's your physical experience. Now, we have to define 10. 10 means call the ambulance. You know, I'm ready to pass out. We had a patient who was referred by the Workers' Comp System of Canada. He was want to be there. They forced him to come. He was on high-dose methadone, high-dose Percocet, the usual. And we, after detox, he was with us for 64 days, and every single day his pain was a 10. All day, every day. And I said to him at the end of his treatment, I said, you know, it's hard for me to believe that your pain is so monolithic that it never goes in any direction other than stay at a 10. He said, well, it might, but you're never going to hear about it. He was an angry guy who took his anger home with him, unfortunately. So what's the goal of pain treatment? The first primary goal ought to be to maintain or improve function. We ought to be after, how's your life? We oughtn't to even be asking about pain. And as a result of the work that we do, the pain goes down. And our treatment goal is reduction of pain by 50%, and we achieve that over 85% of the time. Coming off opioids is a good start, by the way. So what can we do for non-opioid treatment? I was talking to somebody last evening about the class of drugs known as the NSAIDs, non-steroidal Motrin or ibuprofen, aspirin, naproxen, Voltaren. These drugs work on the periphery. They don't work on the central nervous system. I had a patient who was methadone dependent, was going in for a tooth extraction, and he called me up. He said, what should I use for the pain? I said, well, check with the dentist, but ibuprofen 600 or 800 milligrams should do it with a couple of Tylenol. He called me back the next day. He said, that ibuprofen, all it did was take the pain away. So it depends what you're after, right? Tricyclics are sedating antidepressants, old-fashioned Elavil, Pamelar. Sleep disturbance is a big problem for people with chronic pain. And get them sleeping early on. There are some side effects, but they work pretty well. And then the SNRIs are drugs like Cymbalta, the generic is duloxetine, or Effexor, venlafaxine. They work on serotonin and norepinephrine, which are inhibiting tracts inside the nervous system, and they work really well for central pain syndromes. Anticonvulsants, drugs like gabapentin or Neurontin, pregabalin, Lyrica, we use them very cautiously because there are reports of abuse. People can abuse Neurontin. Anybody in the audience have experience with Neurontin abuse? But they're effective for neuropathic pain, particularly. Muscle relaxants, here's a take-home. Any drug but Soma, carazoprodol. Soma is a bad drug on the market. I don't know why it's still on the market. It's off the market in Europe. It's a brain relaxant. It's not a muscle relaxant. There are other muscle relaxants that are somewhat helpful for chronic pain. And then finally, topicals, things that we put on the skin, like ibuprofen in a cream, or Voltaren, anti-inflammatory in a cream, or even gabapentin, Neurontin in a cream, can be effective to diminish the pain. And we're not talking about 4-point reduction in pain score if you rub on some gel. But if you get a point reduction with a gel, and then you get a point reduction with a meditation, and then you get a point reduction after you meditate when you go out for a walk, and then you get another point reduction if you say a prayer, you're down 50%. You haven't even taken an aspirin. So, the treatment approach to non-malignant pain in our culture is if it hurts, let's start with ibuprofen. Good plan. If it hurts a lot, give hydrocodone. We're on the way. If it hurts a really lot, give oxycodone, Percodan. If it still really hurts a lot, give more oxycodone or add a long-acting to a short-acting. If it hurts for a long time, we keep giving more. And if it keeps getting worse no matter what I prescribe, discharge the patient. You know, something wrong with that picture, isn't there? I mean, I got them started in a valid attempt to help, and now we're down the road. So is there a rational use of opioids in chronic pain? Very limited, but it really ought to be based on a clinical trial. If I give you an opioid, and you know, if you have addiction, you're in a little different category than if you don't have addiction when it comes to taking an opioid therapeutically. Just as much trouble, even if you don't have addiction. Because if I give it to you, it'll work, right? But then I'm going to keep giving it to you, and you're going to find out what? It's not going to work as good. Why? Tolerance. So what do I do then? If I increase the dose or give you a stronger medication, we're on a road with no end in sight. So based on ongoing assessments, we ought to say, you know, we're on our third dosage escalation. We're going in the wrong direction. We ought to have an exit strategy to get you off this drug, and we ought to have that exit strategy before we ever get started. Who would take off in an airplane without landing gear? It's what we did with opioids in the United States, and that's how we missed the boat. In our valid attempts to give people relief from their pain, we ended up causing more pain and more life problems. It turns out that the more opioid we give, the more likely to die. CDC came out with some recommendations. They said keep the dose under 50 milligrams of morphine equivalent, preferably under no higher than 90. And here's why, because if we're at 50, you have 3 times the chance of overdosing. If we're up at 100, it's 11 times the risk of overdose. So there's scientific basis to keep the dose low. Guess who didn't like that recommendation? Purdue Pharma, because it's less pills. The next recommendation was don't give lots of pills to people who have acute pain, because it turns out acute pain results in chronic use of opioids if we use opioids. So if we give somebody a 10-day supply of opioids, there's a 20%, actually 21% chance that they're going to be on them at a year. If we gave them a 30-day supply of opioids, there's a 22% chance, 22% chance that they're going to be on them at 3 years, right? Almost a quarter of the people that have a 30-day supply of medicine are going to be on them for a long time. This next, well, we're going to go through these pretty quick, sorry. The next slide is a prescription that I got after a minor surgical procedure. I told the doc that I was in recovery, and here's what she gave me to go home with. 50 10-milligram Percocet. Right? She's got her mouth open. I'd never filled the prescription. But, you know, you have to ask, what was she thinking? So I'll tell you a quick story. There's 3 people on the edge of a river. Beautiful day like today. Sun is shining, the river is flowing by, and it's heading for this beautiful waterfall. In a couple of moments, all of a sudden, we see a baby in the river, bobbing. And another baby, and another baby, and another baby, until the river is filled with babies. Well, the first guy jumps into the river and starts gathering up babies and bringing them to the side and gathering some more babies. The second person goes into the woods and gathers a bunch of twigs to tie them together to make a raft. Well, the third person disappears. Where the hell did he go? He went to the head of the river to find out who's throwing in all the damn babies. Doctors are writing prescriptions for people with a sprained ankle for 50 pills. They're throwing in the babies. And they have to change that behavior. Now, there's legislation out in many states that say you can't prescribe more than a few days' worth of opioids. And you should hear the pushback. I gave a talk a few weeks ago in Las Vegas at Pain Week. Yeah. A pharmaceutically driven conference, let's just say. I'm the only guy who talks about mindfulness practice. That was my lecture. You can imagine how many people showed up. But the message there is, oh no, CDC's, the guidelines are mistaken and we're off on a terrible road. Now, what they did say that's accurate is, what we've done with opioid prescribing is we've cut people off. So we have 16 million Americans who are dependent on opioids who now don't have a source of those opioids. It's not a good plan. because they have nothing to do that's effective for their pain. They're also going to be in withdrawal as they cut down their dose. So bad plan, government. And they did just pass the opiate law, if anybody saw. The Senate passed 99-1 opioid legislation that's going to provide, I think, $9 billion of funding. A lot of it's going to go for medication-assisted treatment. Don't get me started, but some of it's going to go for appropriate pain treatment, research development for alternative measures to opioids that are not habit-forming. There's a lot of problems with opioids. The biggest one is side effects. Now, do you know the worst side effect of an opioid? Anybody? Constipation, right? Well, good news. This was a course at Pain Week for opiate-induced constipation, and here is an ad, Painstipation. Has anybody seen the Super Bowl ad with the hot guy who says, "Oh, I got opiate-induced constipation, but I don't got to worry about it anymore"? You know, the American way. So there are other side effects besides constipation. We actually had a 80-year-old woman who was a maid who had injured her back. She was on workers' compensation, and she took 8 Vicodin a day. She had such bad constipation that she could only move her bowels every 10 days by manually disimpacting herself, putting her hand up her rectum, and she was suicidal. She did not want to live. And we detoxed her, and she got through terrible diarrhea for a couple of days, and then she was back to a good life. But there's problems with sleep apnea related to opioids. There's problem with cognition. There's problems with hormonal levels, so estrogen and testosterone go down, causing a decrease in bone density in both men and women, and there are problems with the immune system. So they're not benign drugs. And with any medication, we have to look at benefits versus harms, potential benefits versus potential harms. Everybody gets tolerant and physically dependent sooner or later if they take opioids. They lose function, they function less well than off. They perceive emotional pain as physical pain. They were termed chemical copers. It turns out most everybody with chronic pain is suffering from emotional distress. And if I take the drug and I find that my marriage gets better, it's not the proper use of an opioid. And finally, opiate-induced hyperalgesia. Here's a graphic representation. This is as good as it's going to get with an optimal dose of opioid. Let's say that's 3 or 4 hydrocodone or maybe Percocet a day. If the pain goes up, which it will because of tolerance, and we drive the dose up, pain level is rising over time. So more pain on the opioid than off. This is a tough sell for patients. And the cool thing that happens is if they're in a group with people who've been there a while, they say, "We thought he was full of crap too, but my pain score is a 2 and I'm power walking on the track and I came in on a walker with an 8. So it does happen. The opioid story is one of a pendulum swinging. In 1900, the ingredient of Bayer aspirin was, anybody? Heroin. That's where heroin was invented, synthesized. Probably not a great idea. A little over. We're giving it to kids who were teething and people who had chronic hysterical pain. Terrible. So the pendulum eventually, by 1918, the Harrison Narcotic Act was passed, and they realized that this was a bad idea. And really, they made opioids illegal to prescribe for anybody who has the disease of addiction. And then, gradually, over the course of the next 30 or 40 years, we came upon the hospice movement. It's a wonderful movement to alleviate suffering in people who are dying. And it doesn't make any sense for somebody to die in misery, in pain. So opioids sometimes, not great, but maybe 30% of the time, are effective for chronic terminal pain. And they started to market the drugs for those people, and doctors started using them, which is a good thing when you think about it. But then came the pendulum starting to swing, and this was where the pharmaceutical folks sat around. We don't have any farm reps here, right? That wouldn't happen. So they sat around a table and they said, "Hey, we've got 20, maybe 30 million Americans are dying of cancer, and they live about 90 days average. That's not much of a market. But we've got 125 million Americans diagnosed with chronic pain, and they're going to be alive for decades. That's our market." And they went after them hard. They went after them with this wonderful invention, OxyContin. They told us falsely that this drug was non-addictive because if you swallow it, it's absorbed gradually into your bloodstream. Nice idea. What did we find out? That they knew all along that you could crush this up and snort it and get high just like heroin. And that's what people were doing. It turns out if you look at the literature before they ever put it on the market, it was in their research data. They never reported it. The president or the CEO of Purdue Pharma went to jail for that for 6 months, and the company was fined $600 million. Do you know what you call that for Purdue Pharma? Chump change. Cost of doing business. No big deal. So, and then what happened? They made it harder to crush. Come on. So now they have this crush-proof OxyContin that has lowered the abuse potential, although my patients tell me that if you freeze it and then put it in the microwave, you can crush it just fine. Or you can use Opana that doesn't have crush proofing. So we can't legislate around the epidemic, and it is an epidemic. If you look at the United States, and just we're going to go from 99 to 2009, and this is treatment admissions for non-heroin opioids, and just look at the red states over the course of 10 years, and watch what happens in the United States. Isn't that something? I gave this talk in Arizona a couple months ago. Everybody applauded when they got there because, you know. So, and this is not Republican voting states, by the way. These are high incidence treatment. We know that prescription overdose abuse is a growing problem. There are more deaths from opioid overdose than motor vehicle accidents. And 42,000 deaths reported in 2016. That's up to about 45,000 in 2017. And what we know is that with the death rate going up, the treatment needs going up, it's really all related to sales. So I'm going to rail just a little bit about the opioid industry because they really did take advantage of the medical profession and of patient vulnerabilities. And they did that by coming into, I'm a family doc, and they came into my office and they said, you know what, doc? You're opiophobic. You should prescribe more liberally because people are suffering needlessly. Come on. They said, opioids are safe and effective for chronic pain. Do you know how many studies they had to prove that? Not one. Now we've got some 3-year studies, and it says less than 20% have mild benefit from opioids with chronic pain. They cited the studies for short-term pain with people who had cancer. They said that opioid therapy can be easily discontinued if you're taking the drug for pain. Why? Does that make any sense to anybody? And then the biggest lie of all was opioid addiction is rare. If you have pain, you can't get addicted. Well, stupid. I mean, that is stupid. But they showed me a study to prove that one. 4 cases of addiction among almost 12,000 patients. Now, if that's true, you can't get addicted. This is a study that's been quoted, Porter and Jick. Do you want to see the study? This was it. I'll walk you through it because you obviously can't read the slide. It's a letter to the editor of the New England Journal. They went back into a hospital. They picked out 40,000 charts. 11,882 had gotten 1 dose of an opioid. And then they went into the chart and looked for the word addiction. And it was there 4 times. That's their study. I mean, it's horrific. But that was their study that they could then go around the country saying you can't get addicted if you take opioids. The way they managed to generate the interest was with advertising. That's an OxyContin ad, that's a Vicodin ad, and the FDA was complicit in this, folks. They allowed these advertisements to say that it was effective in chronic pain when there was no data to support it. The Joint Commission on Accreditation, people familiar with Joint Commission? It accredits treatment programs and hospitals. And they basically said, in their wisdom, that in addition to the 4 vital signs, objective signs, blood pressure, pulse, temperature, and respiratory rate, every shift you have to ask what the pain score is. If I'm a nurse and I have in my shift or 14 people and I got a script on the books for opiates, what am I going to do if you say your pain's an 8? I'm going to medicate you. So this was a big mistake. Joint Commission's walked it back. The AMA has come out against the 5th vital sign, but it's still here, and it's still part of our culture. As we've made it harder to get prescription opioids, which I think is a good thing, unfortunately, this is what's come about. Epidemic of heroin and of synthetic opioids. So if you look at the numbers, they're pretty staggering. 20,000 deaths, from synthetic opioids, including fentanyl, in 2016, and worse still, the next year, 30,000 deaths from synthetic opioids. That's last year. These are synthetic opioids manufactured primarily in Asia, China, easy to transport, being shipped into the United States and laced with whatever drug it is. They make them into pills that look like OxyContin, and they add it to heroin, and they are very potent and unexpected, so people are overdosing and dying inadvertently. So what do we do about this problem? Well, the government and many of the agencies that support treatment methodologies say, recovery, abstinence, 12 steps, nah. But this is what we really want people to have. Methadone, a better opioid. And they've got data sets. This saves lives. People stay alive when they're on a controlled dose of an opioid. You probably know methadone is available only in a clinic for somebody who has a diagnosis of addiction, though it's available in any doctor's office. Problem of pain. Anybody can write that prescription. And methadone in a clinic is maintained and as a result of being on methadone, lower incidence of overdoses, lower incidence of injecting, which means less HIV and less hepatitis, and less criminal behavior. So there is some validity to methadone for people who are opioid dependent, but let's face it, methadone is a terrible drug to come off of. Very dependence-inducing. So we got a new drug, buprenorphine. Goes by the name of Suboxone or Subutex or Valve. And now we've got a injectable form of that, Probuphine, or we've got an implant that lasts 3 months. Reckitt Benziger, who has Suboxone patent, about $4 billion last year. Good news about Suboxone is, one of the speakers I heard at Pain Week said, dead is dead. So if we don't keep people alive, we don't have any chance of treating them. So Suboxone it's a form of an opiate. It doesn't work quite as heavily in the opioid receptor. It's what we call a partial stimulator of the opioid receptor. Therefore, people don't abuse it. There's a ceiling effect. And if you're on Suboxone, it's harder to get high on other opioids. So there's some beneficial effects of Suboxone, unquestionably. My concern is we don't have any documented exit strategy for this medication. And we have a culture and a government that supports getting people on this medication as treatment. Medication as treatment. And what about the treatment and recovery process that some of you in this room know, where you find a way to live without drugs and you have a better life? Suboxone doesn't really offer that. Suboxone offers stabilization, and hopefully, if it's used for a period of time as part of a recovery-oriented systems of care that's a lifelong process, as we talked about, for a better way. Now, Trexone is a drug that blocks the opioid receptor. You can get a pill or you can get an injection. And now there's an implantable form of that. A little more appealing because it's not an opiate. It just blocks the opioid receptor, and there's some goods and bads to that. And finally, naloxone is a life-saving drug, Narcan, which can be administered intranasally or by injection, and if somebody has overdosed on an opioid, it will save their life. Problems with that is it's not at all treatment. There are people who are getting revived 3 times in a day in the emergency room. So simply reviving somebody without a measure of what we're going to do for their is, a futile effort, I think, in the long run. Not that I would ever suggest withholding Narcan. I mean, Narcan should be available for any opiate addict who's at risk of overdose. But it is not a solution to the opioid epidemic. So what's the difference between being addicted to painkillers and just really, really liking them a lot? Actually, I had a patient who said, I don't have addiction, I have. The bottle said 1 every 4 hours, and I took 4 every 1 hour. So American Society of Addiction Medicine, here's the short definition of addiction. It's pathological pursuit of reward or relief. So here's where the overlap between getting high, reward, and relief comes in. Because a lot of people are pathologically pursuing relief. They have pain, it's legitimate pain because all pain is real, and they want to be out of pain. and they take their drug in an attempt, well, it turns out the relief circuitry is inextricably linked with the reward circuitry. Feel some improved mood, and if you have chronic pain and depression, getting a drug that makes you feel a little better becomes pretty appealing. And we end up on that road, and it turns out that the distinction between the pain patient and the drug is an artificial one. The drug companies use that. Oh, it's the junkies, it's the drug addicts that are causing the problems. It's not the 80-year-old grandmother who wants to dance at her son's wedding. Well, the 80-year-old was addicted to her Vicodin and had constipation to the point where she wanted to kill herself. So there's a lot of people taking these drugs by prescription. The data says that 63% of people who use drugs for pain use them for purposes other than pain. 35% met DSM-5 criteria for substance use disorder, opiate use disorder, which is hard to do if you know the DSM criteria. And finally, 92% in one study of opioid overdose decedents had prescriptions for chronic pain. So chronic pain is the cusp of this epidemic. And simply cutting people off of these opioids is a solution. I want to just mention a few of the non-medication treatments that we use in our program and that are well respected in any functional restoration program. Paying attention to function. Movement is key. It's typical for people who hurt when they move to not move. People with fibromyalgia often go to bed because when they move it hurts. My back hurts when I move, but you know what? I took a bike ride down the Rio Grande Trail, and when it was done, my back still hurt. But I got to see this incredible sights along the way. Motion is lotion. Exercise, getting the joints moving, increases oxygenation, it increases circulation, and increases range of motion. I got a rotator cuff tear on my shoulder, my back, but yeah. So it hurts when I do this. But if this is all I do, this is all I'm going to be able to do, and then I'm going to have restriction, and then I'm going to feel bad, and then I'm not going to want to go anywhere. So this is what I do every single day, and it hurts at the extremes. I bet there's a bunch of you that know what I'm talking about. But by increasing and enhancing my range of motion, my shoulder functions better. Chiropractic, there's some data about back pain that supports using chiropractic. Some people do well with it, other people don't. Therapeutic massage, it's a passive modality, but it does improve circulation. And for some patients, it's the only time they've been touched in the last 10, 15 years. Acupuncture changes the meridian flow of the qi, the energy inside the nervous system. It's been around for 5,000 years. I mean, there's some variation of studies, but it certainly looks like it's an effective way. And some of our patients really get significant improvement with acupuncture techniques. A brief word about nutrition. Things to focus on, like hydration and certain foods that are anti-inflammatory, like powerhouse vegetables and certain fruits like tart cherries and blueberries and cranberries, virgin olive oil, walnuts, chia seeds. I mean, there's things that really have some data about lowered pain levels, but who's studying them? Purdue Pharma isn't studying chia seeds, I can tell you that. There's also things to avoid. The worst toxin that people ingest in our culture? Sugar. The worst toxin that some people ingest in our culture? Nicotine. It is an inflammatory substance that it really makes pain worse. But there are also inflammatory foods that increase pain levels that should be avoided, and there are lists of them pretty readily available. The key, I think, is in challenging the thoughts with cognitive behavioral therapy and dialectical behavioral therapy and acceptance commitment therapy, all validated cognitive therapies that are used for pain. DBT, of course, is for borderline personality disorder, but there are efficacy studies with pain. ACT, if you're not familiar with it, Stephen Hayes from the University of Reno did studies in its efficacy for chronic pain. And then engagement in the process. Just like 12 steps treatment is efficacious for addiction treatment, being in a group of people who understand. So one of the problems is some patients go to treatment and they sit in a group and they say, oh, my back hurts, and everybody in the room says, you're full of crap. You're in denial. You're just an addict. Well, no, that's not really the truth. The truth is they might be an addict and they have a chronic pain condition, and they need attention to both of those. They need to be able to identify and relate to other people, and they need to see recovery in those people different than they've really seen in their entire life. Mindfulness-based stress reduction, spending time with people and their thoughts. John Kabat-Zinn is one of the authors of a book called Full Catastrophe Living. We teach people how to meditate. We teach people how to just notice what's present without judging it. Very powerful intervention technique. And yoga and qigong. We know that yoga works from the bottom up physically, but also from the top down cognitively. Excellent exercise, and we also have a qigong instructor. Now, you may know this, you may not, but research actually confirms that drugs give the same benefits as yoga. Anybody know that? So here's the halasana pose, and you can see that the drug works pretty well for this guy. Balasana, child's pose. He can't get his hips down either. I have trouble with that. And finally, Savasana, corpse pose. He's got that down 100%. So I'm going to close with a reminder. The truth is that the pain is real. Please pay attention to that if you're dealing with somebody with pain, and don't discount their self-report, and help learn the clinical skills to redirect them to, yes, you have a lot of pain, let's go for a walk anyway. We'll go as far as you can, and then we'll come back. I had a patient who went for a long walk, and he said, you know, you should have told me to go half on the walk because I had to get back. So keep that in mind. Emotions and the thoughts associated drive the experience of chronic pain. Opioids often make the pain worse. If we're going to treat pain, let's make people better. Let's restore and improve function. And finally, expectations influence outcomes. So if you thought you were going to have a good time this morning, Claudia Black is speaking next, and you're going to have a great time. This is hard work. This is really hard work. But I'll tell you, this is the closest thing in my clinical experience to miracle work I've ever done. Seeing people come in depressed, discouraged, despondent, and disabled, and turning to a place where they have a shine and a light in their soul. But this woman took her husband to the doctor, and he said, your husband's suffering from a severe stress disorder. There's the guy getting dressed. He has chronic pain and addiction, but if you do the following, he's going to regain his health completely. Give him 3 nutritious meals a day, candlelight dinner, take him to the gym, make sure he doesn't have any stress, have sex with him 1 time a week. Or 3 times a day, however you... If you do all this, he's going to regain his health completely. What did the doctor say? You're going to die. Thank you very much.